Hi, Dr. Martinez, Lage.
Hello.
How are you?
Good. How are you?
Good. Thank you very much for joining us.
You're welcome.
Let me wait for another minute and then I'll introduce you and then we can get started. Yeah.
Sounds good.
Okay, I'll introduce you now. Please welcome Dr. Martinez Lage. She is very busy person and yet she's taking time to go over some neuro cases with us. She is a neuropathologist at Massachusetts General Hospital in Boston and has been a neuropathologist there since 2016. She's also Associate Program Director at MGH Pathology. We welcome you, Dr. Martinez Lage, and we really look forward to learn from you.
All right. Thank you very much, Akanshka. Feel free to guide me along the way on whatever you're interested in. We can get started whenever you're ready. Are we waiting for a lot of other people?
Yeah, there will be people keeping on coming. We can get started. I made you co-host, so you can go ahead and start sharing your screen.
Great. All right. Okay, I assume you can all see my screen now?
Yes.
All right, great. So welcome everyone. I'm very happy to be here working with you through some of these cases. Full disclosure, I don't use PatPresenter all that much, so it might be a little bit clunky. But we'll do our best. I got a list of entities that you were interested in, so I opened a few of these cases already. So just to jump right in, starting with this tumor that is a very distinct pattern of a glial neoplasm. Why do I call it glial? Because it has these structures and cytoplasm that are all fibrillary with these like elongated nuclei. It's quite cellular, but what's more striking about this tumor is this arrangement around vessels in which you can see that there are nuclei arranged against this empty area without nuclei and then a vessel in the center. This is a classic description with a perivascular pseudo rosette looks like. And it is one of the findings that we look for in an ependymoma. So ependymomas are tumors of ependymal origin. The ependymal cells are glial in identity, but they also have some epithelial features, including presence of cilia, microvilli, and tight junctions. Ependymomas can occasionally resemble infiltrating astrocytomas in some cases, but the characteristic disposition around vessels like this perivascular pseudo-rosettes is very typical. Other features that we would look for are not as well represented in this example, but here you can see how the same perivascular pseudo-rosettes and they're a little bit discohesive. Let's see this down there. And then I think this other example here had better demonstration of the other characteristic feature, which is the true or ependymal rosettes. What we're looking for there is the actual formation of a lining similar to the ependymal lining. So a true lumen surrounded by the tumor cells. This is very characteristic again of an ependymal differentiation because it resembles the ependymal lining. So ependymomas are usually well circumscribed tumors. They can occur in the posterior fossa, predominantly in children, but they can also be seen in the adult. Here's an area where you can actually see a pretty nice, well demarcated, straight demarcation between the tumor and the surrounding brain. The current classification that's coming up is using some of the molecular information as well as the location of ependymomas for the classification. So the current types of ependymomas depend on where you are and whether or not they have some particular molecular changes. So we have supratentorial ependymomas. And if you can further classify, there are two types of supratentorial ependymomas that have particular fusions. One of them are called ZFTA fusion positive ependymomas, which used to be called the old Raleigh fused ependymomas. Now they have changed the name because that's the partner of the gene that was known as REL-A. And not always you find REL-A, but you do find ZFTA as part of the rearrangement. There are also YAP1 fused ependymomas, but again, if you don't have that information, you're perfectly fine with just the designation of supratentorial ependymoma. In the posterior fossa, similarly, you can have two different groups based on the molecular findings. They're called PFA for posterior fossa A and PFB for posterior fossa B. And the PFA is the one that best carry a worse prognosis, and it can be identified by using trimethylation mark in the H3K27 gene, the H3K27 trimethylation mark. If there is loss of that expression of the methylation, that designates that it is a PFA group ependymoma, which carries again a worse prognosis. Lastly, there is a spinal ependymoma, so they can occur in the spinal cord. And within the spinal ependymomas, there is one type that can have a MYC-N amplification, and those are usually higher grade, but also worse prognosis. Histological grading of ependymomas has always been a little tricky. They're either grade 2 or anaplastic ependymomas grade 3. In the new classification, we're just going to say grade 2 or grade 3, and usually drop the word anaplastic from many of the designations in brain tumors. So things like necrosis can occur in grade 2 ependymomas. That's not sufficient, especially if there's geographic type necrosis, which is not uncommon. But then the presence of increased mitotic activity and significant anaplasia are the two things that are the most important in terms of designating a tumor as grade 3. But the challenges of histological grading are very well known, and in reality, very frequently, ependymomas are treated the same, whether we call them grade 2 or grade 3. All right, and then those are grade 2 and 3 ependymomas, and then we have this grade 1 subependymoma, which is usually or very frequently an incidental finding. These are very slow-growing tumors, occasionally found at the time of autopsy, rarely presenting with symptoms because they occasionally can include the ventricular system. As you can see, these tumors are a lot less cellular in general, and they have a very characteristic pattern of alternating areas of nuclear-rich islands and anuclear zones. When you look at the cells, they are quite bland, elongated, similar to ependymal cells, but you will not find in a subependymoma either perivascular pseudo-rosettes or true rosettes for the most part. You can find other things that occasionally occur in slow-growing tumors, like, for example, hyalinized vessels. I'm not sure we will see that here. And then cystic change as well is relatively classic, with some myxoid matrix in the cysts. So again, subependymomas, WHO grade 1 lesions are usually not recur after they are surgically removed and occasionally appear incidentally. All right, and then to close the ependymoma category, that was pretty fast. We have this lesion that arises pretty much exclusively in the Cauda equina of the spinal cord. These tumors are usually, they can be variably cellular, and as you can see here, They're characterized by these densely hyalinized vessels, with the tumor cells arranging themselves around the vessels in a pseudopapillary way. And then occasionally these densely hyalinized vessels become like basically almost like hyaline balls, with or without associated tumor cells. In some of these cases, you also can detect a myxoid matrix in the background. Like, for example, here you can see a little bit of this blue myxoid material interspersed with the tumor. So this is a myxopapillary ependymoma. And again, the reality is that sometimes myxopapillary ependymyomas are neither myxoid nor very papillary. But if you use the location as your main reference, you will always be correct with this diagnosis. These tumors were historically grade AA or grade 1. But the current classification recognizes that these tumors recur locally more frequently than it had been acknowledged before. So from the 2021 CNS5 classification, these are going to be ascribed a WHO grade 2. All right, that was really fast. Any questions about any of these?
Yeah, I have a question. So do you do immunostains in these tumors ever? And if you do, like, do they help you?
Yeah, so for example, in some cases of ependymomas, and that's a very good question. Sometimes, and I think the first case here has a little bit of that, some areas of ependymomas can actually resemble an infiltrating astrocytoma. And so sometimes we do occasionally, if there's no if the features of pseudovascular, perivascular pseudorosettes or true rosettes are a little bit hidden, sometimes we use immunohistochemistry in that case. And so what we use, these tumors will be GFAP diffusely positive. So in that sense, there's no difference with other astrocytic tumors. But EMA is what usually can be very helpful. And with EMA staining, you will find it will highlight the true rosettes if they are there, the lumen. But it can also show dot-like or ring-like cytoplasmic staining. And if that is diffused through the tumor, that is pretty good confirmatory evidence that this is an ependymoma. In terms of other immunohistochemistry, we do tend to do Ki-67 and record the proliferation rate, even though it's not a, and here's a mitotic figure, even though it's not a official grading criterion, but we do report it. And then, as I was mentioning, for posterior fossa ependymomas, we do H2K27 trimethylation antibody.
Yeah, this trimethylation H2K27 is interesting because I think there is another tumor in the CNS that is H3K27 methylated.
That's correct.
Yeah. So is this a new new entity now in WHO or as yet?
It is in the upcoming classification. The posterior fossa ependymomas are their own entity.
Right.
Yes.
And
posterior fossa A and posterior fossa B.
Right. Got you. And what about like, is IDH studied in the ependymoma at all? Does it carry any prognosis symptoms?
IDH?
Yeah.
So by definition, if you find an IDH mutation, that tumor is not an ependymoma, no matter how much it looks like an ependymoma.
Right.
So, so if you are, that's a really good point. If you are hesitating between, is this an ependymoma or is this an astrocytoma, for example, an IDH mutation will help you because it will confirm that this is an astrocytoma and not an ependymoma.
Right. Another point that comes into my mind is like these myxopapillary ependymomas, like they have mucin, they have this kind of, I should not say epithelioid, but similar looking cells. And does cytokeratin stain help us to rule out a metastatic carcinoma, if at all? Question.
Absolutely, yes. So cytokeratin stain should not be diffusely positive in ependymomas, but with the caveat that AE13 does have a significant cross-reactivity with GFAP. So, be careful with that. But again, if you have diffuse GFAP expression, that would support ependymoma. And then it's with myxopapillary ependymomas in the same way with subependymomas. They're not as frequently positive with EMA. So that might be a little more tricky. So it will be important to also, check with your surgeon, see what their impression was. These are usually described as a sausage-like tumor that is not intrinsic to the core, but extramedullary. The other thing is myxopapillary ependymomas are usually quite bland. When you look at the cells, there's usually monomorphism. There's not really a lot of mitotic activity. So I think those things would also help you in the differential with a metastatic carcinoma, for example.
Got you. Anyone else
yeah,
has
and you
any questions?
I was going to add, you can do a mucin stain or an Alshan blue, and it highlights the mucin in the background, which is also, in addition to being pretty, it's helpful in the diagnosis.
Got you. Anyone else has any questions? To ask any questions? Okay.
All right. Okay, so I guess then we can move on to meningiomas, which was next. I did not open all of these. All right, so meningiomas are tumors of the arising in the leptomeninges. They are not, so they're described as dural based because they are attached to the dura, but the cell of origin is not the dura itself. They have some characteristic features, including the level of the cytology. Most of the cells in meningiomas are elongated, round to elongated. This is actually a little bit, here we go, let me do this one first. They are these round to elongated, usually monomorphous or very bland looking cells. Importantly, they have cytoplasm that is indistinct from one cell to the next. So there is no distinct cytoplasmic border or membranous borders for the most part. Some occasionally you can call that like syncytial type cytoplasm. And then their characteristics are that they usually tend to form different histological arrangement. One of the most classical ones being world formation, which I'm not seeing here a lot of. So let's see if other examples have better representation of the typical whirling of a meningioma. This one does not really have the same. These are actually lobules, and this is the typical what we would call a meningothelial pattern of a meningioma, in which they're arranged in this large nests or lobular-like arrangement. Tight whorls that are associated with the formation of samoma bodies here's an example of whirling. So this is the expectation that you will have when you're diagnosing an ependymoma, and sometimes, a meningioma, and sometimes you can see it on a smear, for example, on a frozen section. This arrangement of the cells wrapping around themselves and then occasionally creating calcification that is concentric, and those are the famous samoma bodies. So all these meningiomas that are here are not great examples of whirling. All right, so this would be a meningothelial meningioma. There are a large number of variants for meningiomas, including meningothelial, including fibrous meningioma, which I think there was one here. Fibrous meningioma classically has actually, this is not a fibrous meningioma. This is a sammomatous meningioma. So this one has a lot of these concentric calcifications. There are samoma bodies of varying sizes. And if you notice, there's very little tumor cells in between all those sammomatous calcifications. So this is typical of a sammomatous type meningioma. Sammomatous meningiomas are frequently found in the cord, along the spinal cord, so in the thoracic or cervical spine. And they're more characteristically seen in women of middle age. All meningiomas are more frequent in women than they are in men. I was focusing here because there's another example of cytological features that is typical of a meningioma, which is a pseudonuclear inclusion. All right, so fibrous meningiomas are more spindled, and they can have quite a bit of collagen. And then transitional meningiomas, which have features between meningothelial and fibrous meningiomas, have a lot of pseudomoma bodies and very tight whorls. Let's see what else we have here. Okay, so this, once we get to the diagnosis of a meningioma, right, what we care about is grading. Grading of meningiomas can seem a little bit overwhelming, but it really comes down to only a few different options that you have. So the easiest thing, if you think about objective criteria, is the mitotic rate. So if you have a meningioma with less than 4 mitotic figures per 10 high power fields, that's a WHO grade 1. If it is between 4 and 19 mitotic figures per 10 high power fields, that's a grade 2. And if it gets to 20 or more per 10 high power fields, that is grade 3. And importantly, that refers to any area of the tumor that has the highest mitotic rate. So you're going to have to be looking for those areas throughout your sample. So that's one way of grading meningiomas, mitotic activity. Then there are other histological features that are associated with, worse prognosis or a higher rate of recurrence in meningiomas. And there are 5 features, of which you need 3 in order to call a meningioma atypical meningioma, which is the WHO grade 2 meningioma. And those features include nucleoli. This is actually a really good example of very prominent nucleoli in a meningioma. So that's one feature here. I like to be able to see the nuclei when I'm looking at with the 10x power, because if you look too close, it's always easy to find nucleoli. But I think for them to be relevant, they have to be quite prominent. So I do like to be able to see them at 10x. So that's one feature, nucleoli. Another feature is the presence of necrosis, which in meningiomas is very typically found as micronecrosis, so very focal areas of necrosis. Some of these tumors can grow quite large and develop infarcts. So when that geographic type necrosis, that is like a large area of necrosis in the center of a meningioma, that does not count as an atypical feature. But this is actually an example of what the typical micronecrosis foci look like in meningioma. Frequently, you're seeing these like really pycnotic small nuclei falling apart, and then they're scattered throughout the tumor. So here we have already micronucleoli and necrosis as part of the potential atypical feature. So the third one is the presence of loss of the architecture of the meningioma, so sheeting or loss of architecture. Notice that areas like these here, where there's like no distinguishable lobulated or fascicular architecture or whorling, that's what we would consider sheeting. So areas of just tumor growth that is very uniform. That's number 3. And then number 4 is small cell change. And what am I missing? Am I missing something? Macronucleoli necrosis, small cell change. Oh, hypercellularity, excuse me. So hypercellularity can look a little tricky because these tumors can be a little tricky. So these tumors are frequently cellular, but what do we define as hypercellularity as an atypical feature? So you want to look for areas where the tumor cells the tumor nuclei actually overlap with one another. I think this case here does not really have a lot of areas of hypercellularity, but in this case, from what we've seen so far, I would say that we have nucleoli, we have necrosis in multiple areas, and we have sheeting. So all of those things, there's 3 out of 5, would be sufficient for a designation of atypical meningioma. Here's an area where you can find mitotic figures. So I think in this case, it would probably be relatively easy to get to at least 4 mitoses per 10 high power fields. Here's another one. So that probably would support, here's an atypical mitosis, that probably would support your diagnosis of atypical meningioma, WHO grade 2. well, in addition to that, something I didn't mention because it is not part of the 5 atypical histological features, but a different separate feature of worse prognosis is brain invasion. So here you have the boundary between the tumor and the background brain. You can see there's neuropil in the background and these large astrocytes that are reactive. So you have evidence of gliosis, which is already evidence that there's some sort of interaction between the tumor and the underlying brain. For brain invasion, you want to see tumor cells directly in contact with the neuropil without intervening leptomeninges or PIA. So, for example, in an area like right here, you can kind of see that you still have leptomeninges, or excuse me, yeah, PIA matter and leptomeninges. So that might not be the best for brain invasion, but here there's really nothing in between the tumor cells and the brain. So brain invasion, which is this typical tongue-like pattern, is in and of itself a designation for WHO grade 2 tumors. So if it's an otherwise WHO grade 1, even if it doesn't have any of the other features, but you see brain invasion, that makes it WHO grade 2. Notice here, this is not brain invasion because what we have in the background is not neuropil, but collagen. So it's not an area of brain invasion. There are many types of different histological types of meningioma, right? And there are some that are associated with higher risk of recurrence than others. And historically, there used to be some that were designated WHO grade 2 or grade 3 simply based on their histological type. And so here I think we have an example of a couple of those. So cordoid meningioma is here, and clear cell meningioma were considered WHO grade 2, whereas papillary meningioma and rhabdoid meningioma were considered WHO grade 3. Importantly, now again, the 2021 classification is going to ask that in addition to having that designation, you also have features sufficient for a WHO grade 2 independent of that. So you have to have mitotic activity or some of the atypical features to really call one of these tumors WHO grade 2. All right, so let's see what these look like. Here is a cordoid meningioma. So cordoid meningioma, as you can imagine, is going to resemble some features of chordoma, right? And so this is actually a really, really nice example. So this is a tumor that is growing in cords of epithelioid eosinophilic cells with a background of myxoid stroma. As you can see here, that's again the blue myxoid stroma. So this is a good example of a cordoid meningioma, which again, it would have been classified as a WHO grade 2 tumor, but in the upcoming classification, you will only be able to call it that if you also have all the features expected for an atypical meningioma. So cordoid meningiomas can have cordoid areas in different proportions. So we used to consider that you wanted like at least 50% of the tumor to call it cordoid, but again, now that's a little less essential based on the need for the other features. So here's an area of what I was trying to mention earlier of geographic or infarct type necrosis that should not be considered a micronecrosis or an atypical histological feature. And then let's see. Here is a clear cell meningioma. So what you're looking for, again, it's similar to other clear cell neoplasms. You're looking for optically clear cytoplasm with nuclei that are predominantly in the center of the cell. The reason I emphasize that is because some areas that might look like clear cell in reality are microcystic in meningiomas. And in those areas, the nuclei are kind of like to the side of these large vacuoles, and that has no relevant meaning in terms of prognosis. So there's a good example of a clear cell meningioma here. We've seen atypical meningioma. We've talked about clear cell and cordoid meningioma. So what about WHO grade 3 meningiomas? Those are called anaplastic meningioma. And for that, the histological features are different from what we were talking about with atypical meningiomas, and include 20 or more mitoses per 10 high power fields. But also, if you have a tumor that is so anaplastic, so atypical that you might have trouble realizing whether it's a sarcoma or a carcinoma instead of a meningioma, that is also a feature of an anaplastic meningioma, WHO grade 3. So for example, a tumor that looks malignant and resembles a sarcoma, but then you're able to determine that it is a meningioma, whether because it has definitive features of meningothelial differentiation in some areas of the tumor, or because you can use immunohistochemistry to prove that. That's how you come to anaplastic meningioma, WHO grade 3. And then, as I was mentioning earlier, papillary meningioma and rhabdoid meningioma are the two types that are historically been assigned to WHO grade 3. But now you also need the other features for that grading system. In terms of what do you use for immunohistochemistry to support this? So classically, meningiomas will be positive for progesterone receptor, which is a nice nuclear stain. They can be widely positive for EMA, usually with a membranous pattern of staining. But the most robust or recently described immunohistochemical stain that supports meningothelial differentiation is somatostatin receptor 2, SSTR2, which seems to, all of these stainings, all of these proteins I'm mentioning, kind of the proportion of positivity will decrease with increasing grade. So WHO grade 3 meningiomas will have lower proportion of these positivity for these markers. But of those, SSTR2 seems to be the most stable or the most robust. I mean, I have to say that looking at this tumor so far, I'm not seeing all the features of an anaplastic. It might be that it has some areas where there's 20 mitotic figures or more per 10 high power fields. Other than that, what I'm seeing is necrosis. I'm seeing areas of mitotic activity. So more like an atypical meningioma, WHO grade 2. In what I can tell. Right, I think there was at least listed, yes, a rhabdoid meningioma. And as the name suggests, what you're going to see in rhabdoid meningioma is morphology of the cells with really large, glassy eosinophilic cytoplasm, almost like sometimes it looks like a true cytoplasmic inclusion, and with a nucleus that is somewhat displaced to the edge. Other thing that rhabdoid meningioma show is this relatively distinct cellular borders between one cell and the next. As I mentioned earlier, that's not very typical of most meningiomas with meningothelial differentiation. So rhabdoid meningiomas, again, are usually associated with behavior that's similar to WHO grade 3. However, more recently, the knowledge is that, not every tumor that we historically called rhabdoid meningioma actually does poorly. And so now we have a molecular and immunohistochemical marker that actually helps with that differentiation. So tumors that are truly going to behave badly as WHO grade 3 are actually going to show loss of expression of the protein called BAP1, BAP1. If you have something that looks like a rhabdoid meningioma, but it retains BAP1 staining, then you want to not call it a WHO grade 3 tumor, and then just use all of the other features to determine whether it's grade 2 or 1 based on other histological features. So this is actually a really, really good example of a rhabdoid meningioma, very homogeneously showing similar architecture and morphology everywhere. I do not think we have an example of a papillary papillary meningioma. Those are quite rare, and they really usually have this like pseudopapillary appearance, in that basically they're falling apart, they're discohesive, and the cells tend to hang out around vessels, as in other pseudopapillary morphology. All right. Any other questions about meningiomas?
Yes. So according to the current WHO classification system, is there any reporting recommendations to, or especially these fibrous, meningothelial, transitional, do we report it in our reports, and what are our steps in reporting?
Right. So you don't have to, because there is really no prognostic implication whether whether meningioma is fibrous or meningothelial or transitional. So there is no requirement to report those things. We frequently do not. We just focus on the grading, except for obviously those that do have some prognostic meaning, as we were talking about: clear cell, cordoid, papillary, and rhabdoid meningioma. You want to report the features that make you decide that a tumor is atypical meningioma, WHO grade 2, and spell out how you got there, is the number of mitotic figures, etc. And then whether or not there's brain invasion. Importantly, in meningiomas, you can have, depending on the location, right, you can have involvement of the bone, or even involvement of other soft tissues if it's in the skull base. Those things are not going to change the grade, but it might be worthwhile commenting on them. I think that's really all there. Yeah. Oh, and we, in our practice, so the main reason to grade is, to kind of provide the expected natural history of these tumors, right? So grade 3 tumors are likely to recur. Grade 2 at like about to 40–50% supposedly to recur in like 5 to 10 years. Grade 2 are about 10 to 20% likelihood of recurrence. And then grade 1 are very low probability of recurrence. Long-term is low. However, we know that there's a spectrum of those, right? Some grade 1s are never going to recur. Some grade 1s may recur. And so one of the ways that we can try to approach that differentiation is actually using the proliferation rate Ki-67. So we, in our practice, we do Ki-67 in all of WHO grade 1 meningiomas. We don't necessarily report it or do it in grade 2s or grade 3s because there's really no implication of that in those. And we tend to use the cutoff of 3% as the significant between, relatively low grade and relatively higher grade of probability of recurrence. Does it answer your question?
Yes, thank you very much.
So, sorry, you mentioned that to be classified as grade 2 or grade 3 with the new revision, you have to meet the criteria for those. Could you also have one of the typical grade 1 histologic features and still be classified as like a grade 2 meningioma then?
Yeah, absolutely. And that's what has been historically the case, right? So if you have a tumor that looks, grade 1, but you find the atypical features, that makes it an atypical meningioma, which is a WHO grade 2.
Great, thank you.
Is it okay?
But then in cordoid, clear cell, papillary, rhabdoid, even if you have these morphologies, unless you have the atypical / anaplastic features, you cannot call them grade 3. That's correct?
That's correct. Yes.
Okay. Yeah.
Yes. All right. Let's see. What else was your list? Oh, okay. Have hemangioblastoma. So hemangioblastomas are actually quite unique lesions. They are a CNS tumor of vascular differentiation. They have two presentations. They're either sporadic or in the context of von Hippel-Lindau syndrome. They're very characteristic radiologically in that they are one of the classical entities that present with the typical cyst with a mural nodule pattern. And they are more common in the posterior fossa, but they can occur anywhere pretty much in the CNS, including the spinal cord and supratentorial. So these tumors are characterized by a innumerable vascular channels that are usually these really tiny, small capillaries that are admixed with these vacuolated cells that are called stromal cells. So these stromal cells can have relative nuclear atypia. Sometimes they can be a little bit pleomorphic, but for the most part, they're bland. They're intermixed with all these vascular channels. And again, notice how the vascular channels are pretty thin, so they're endothelial lined only. And that's basically what characterizes a hemangioblastoma. Other things here you can see is a sharp demarcation with the surrounding brain tissue. What you can see in this brain, actually, it's interesting. So we, let's see, as I was saying, frequently we're in the cerebellum. I don't think here we have necessary demonstration of that. But what you can see, and it's also an important thing to note, in this area here, is this neuropil with these really bright eosinophilic corkscrew appearing refractile structures. And these are Rosenthal fibers. So Rosenthal fibers are basically specialization, so to speak, of astrocytic processes. So they would be GFAP positive if you were to do that. And we always think of them as an effect of something that's slow growing. So when you have a lesion that is slow growing, the brain around it will react. And one of the ways that they react is with the formation of Rosenthal fibers. And the background is called pyloigliosis. So why I'm mentioning this is because Rosenthal, there's actually a lot of Rosenthal fibers here. You may have, be familiar with the fact that Rosenthal fibers are common in pilocytic astrocytomas, but they are not unique to that tumor, and they can actually be present in many things that are not the tumor or a tumor itself. So pyloigliosis with abundant Rosenthal fibers can be seen in the periphery of hemangioblastomas, but also other low-grade or slow-growing tumors, like, for example, craniopharyngiomas, very classically. So just to keep in mind that if you see Rosenthal fibers, it doesn't mean that it's a pilocytic astrocytoma. Because these are quite hemorrhagic, it's not uncommon to get gel foam, like this is what you see here, this surgical material gel foam that comes with the specimen, because these can be quite challenging during the surgery. These are WHO grade 1 tumors. And of course, I was mentioning that you can see them in the context of von Hippel-Lindau disease or syndrome. And in that context, you may want to make sure that what you're seeing is not metastatic renal cell carcinoma, but rather hemangioblastoma. So that's the one case where we would use immunohistochemistry to confirm that the entity we're looking at is a hemangioblastoma. And in that differential diagnosis, one of the most helpful things is inhibin, which will be positive in hemangioblastoma, but negative in RCC. And you can also add, for example, PAX8, which would be positive in RCC and expected to be negative in hemangioblastoma. Questions?
So hemangioblastoma will always be WHO grade 1. There is no grade 2 of hemangioblastoma.
That's correct.
Okay.
Yeah. All right. What should we look at next? Corplexus. Not sure that we will have all the entities, but corplexus tumors include choroid plexus papilloma, atypical choroid plexus papilloma, and choroid plexus carcinoma. So let's see what we have. So choroid plexus papilloma are lesions that arise, as you can imagine, in the choroid plexus. So they're usually present in the ventricular system. And as you can infer from the name, papillomas are basically just growths of quote unquote well differentiated choroid plexus neoplastic epithelium. So what you're going to see is preservation of the papillary growth, with these very characteristic growth of the choroid plexus cells around fibrovascular cores. There should be no solid growth and no significant mitotic activity for choroid plexus papillomas WHO grade 1. If you have significant mitotic activity or solid growth, you can start considering an atypical corplexus papilloma, which would be a WHO grade 2 neoplasm. And then choroplexus carcinoma is relatively rare, is more commonly considered a tumor of infants. So patients that are 2 years or younger develop choroplexus carcinomas. And in those cases, you're going to see true invasion of the underlying brain parenchyma. And and also features of dedifferentiation, in which sometimes you can't really tell that tumor is a choroplexus origin unless you see different areas of the tumor. So choroplexus carcinomas can actually become quite large and present in young children with a tumor that's filling almost the entire hemisphere. And they can be seen in Li-Fraumeni syndrome with p53 mutations. So see here, for example, this is an area where these areas seem to be actually invading into the parenchyma. It's no longer the papillary growth, but almost glandular-like appearance. So I would be considering that this is no longer a choroplexus papilloma grade 1, but rather is at least grade 2 and potentially considering possibility of choroplexus carcinoma, maybe in other areas of the lesion. In terms of, obviously the most significant pitfall is considering metastases, right? Especially the adult population. So metastatic adenocarcinoma can look very much like choroplexus papilloma. So things that you could use, these are usually they're usually negative for keratin 7 and keratin 20. But you can use transthyretin, which tends to be positive in choroplexus and choroplexus neoplasms. They can also be positive for S100. And I think that's pretty much all the markers that we tend to use. Transthyretin is supposed to be the most specific for choroplexus. And then again, the other clue is that these would be usually lesions that are solitary as opposed to multiple lesions, in which metastatic carcinomas more often than not will be more than one lesion in the CNS. And then the degree also of bland appearance of a papilloma as opposed to a metastatic carcinoma that usually has at least some elements, unless they're very well differentiated. So that's one caveat to consider. They do tend to calcify significantly. You see here all these areas of calcification. So sometimes these tumors become enlarged and quite hard at the time of surgery. So that's another clue for a choroplexus papilloma, that they can get quite calcified.
That's great. Is there any, like you said, that more than 2 mitosis will be a typical choroid plexus papilloma? Is there any cutoff for choroid plexus carcinoma as well?
No, for that you're going to have to look for invasion and for areas of solid growth.
Got you. Okay. Are there any WHO changes in the current classification of?
You know what? Not that I am aware. I don't think so. I don't believe so. At least not something that has been highlighted in the summaries that have come out so far. But I don't believe so.
I have an unrelated question. So in institutes where we don't, like, it's totally unrelated. I'm talking about astrocytomas and glioblastomas here. An institute that does not have IDH. So according to the new classification, they basically are calling IDH mutant anaplastic astrocytoma as well, grade 4. And the IDH wild types have been completely calling as glioblastoma, if I'm not wrong. So if you don't have IDH, how do you top line your diagnosis?
Right. So so the new classification, and actually the C impact summaries that have been coming out since the 2016 classification provide nomenclature for these situations. So they offer 2 terms, which are NOS or NEC. So NOS stands for not otherwise specified, whereas NEC stands for not elsewhere classified. And so there's a difference between the two. Not otherwise specified means I should do something for classifying this tumor correctly, for example, IDH, but I didn't do it, whether I don't have access to the technology, there was not enough tissue. It was determined that the patient was not going to receive additional treatment, so we just didn't do it. So in that case, you will say, you know, infiltrating astrocytoma or infiltrating glioma, if you want to, you know, not be committal in terms of whether it's astrocytic or oligodendroglial, NOS, and then explain that the designation of not otherwise specified comes from the absence of information of the IDH status of this tumor, which would be necessary for the classification. So yes, one example, what you were saying, right? You might have a tumor that looks like a glioblastoma, right? So you have all the histological features that classically are glioblastoma. But at this point, the expectation is that you would have at least the immunohistochemical stain for IDH, even if you don't have sequencing, and a negative immunohistochemistry for the canonical mutation of IDH. In patients that are older than 55 years old with high-grade astrocytomas with microvascular proliferation or necrosis, or what we would have called glioblastomas, it is sufficient to just have the immunohistochemistry as negative. And you can call those IDH wild-type glioblastomas. If the patient is younger than 55 years old, then you have to say, astrocytoma WHO grade 4 NOS, and explain that you don't know whether it's IDH mutant or not.
Perfect. Thank you very much. Thank you.
Yep. Yeah, of course. All right. I guess, I mean, we have 10 minutes, but I guess we could talk about pituitary adenomas in that time. So pituitary adenomas, pituitary tumors are the most common lesion arising in the sella. Excuse me. I don't know why. Oh, there we go. Okay. Some examples. Okay. So pituitary adenomas are basically neuroendocrine tumors, right, that arise in the anterior portion of the pituitary. And they are by far the most common tumor in the sellar location. There's a difference between what is more common clinically and what is more common in our, surgical service, or even, under our microscope. So these are tumors that arise from the cells that make pituitary hormones. There are 6 pituitary hormones: growth hormone, prolactin, ACTH, gonadotroph, so FSH or LH, and TSH. So those are the 6 hormones that are made in the pituitary. And tumors can arise from cells that make any of these type of hormones. They can present clinically with either expression of the hormone that is released into the system and can create a target syndrome. So the most classical of those two are Cushing syndrome in tumors that make ACTH and release it into the system. Cushing syndrome is actually usually associated with tumors that are quite small, or microadenomas that make ACTH. And then acromegaly is the other one, which is caused by an excess secretion of growth hormone, GH. Then if a tumor is not making enough hormone to create a syndrome, it can present with other things, predominantly with a growth that causes compression of the structures around it, and most commonly creates headaches, and can cause homonymous hemianopsia due to compression of the optic chiasm. We call, tumors that don't make a functional hormone, we call those non-functional adenomas, or that's how they clinically are usually referred to. So there are, the most common tumor is the non-functional adenoma, but there's also a very common one, which is prolactinoma. So prolactinomas are quite common, but they're treated medically, so they're not frequently seen in the in the pathology department. When we get them, they're usually post-treatment, and so they have had some fibrosis or some changes that are not naive to treatment. So, why do we care about classifying pituitary adenomas? Well, we care because there's different expected biological behavior from tumors that either make one hormone or the other. And of course, also it can help with follow-up and monitoring of the disease. So historically, we've done that with, in the past, we used to do electron microscopy. Now we have done immunohistochemistry for the 6 hormones for a really long time. Now the latest classification incorporates a new avenue, which is the use of transcription factors. So transcription factors are expressed in nuclei and nucleus, and they have secondary downstream protein expression to create the hormones themselves. And so they simplify things a little bit in that there are basically 3 families of pituitary adenomas. There is the family of pituitary adenomas that express transcription factor called SF1 or serotogenic factor 1. And those are the tumors that are gonadotrophs. So they make FSH or LH, or not really one or the other, but if they express SF1, they are gonadotroph adenomas. Then there's a family of tumors that make ACTH, and the transcription factor associated with those is called TPIT, TPIT. That's the only member of the family. And then all the other adenomas pertain to the same family that's called PIT1. PIT1 is a transcription factor, and then those can make either growth hormone, prolactin, TSH, etc. So how do we diagnose a pituitary adenoma? Well, we're going to have a cellular lesion, and then what we're going to see is usually a very uniform epithelioid neoplasm with growth that can be in the form of nests or trabecular, or very similar to what you can think of any other neuroendocrine tumor elsewhere in the body. It will usually, it can have variable morphologies if the tumors are quite large. And then the cytology of the cells, you will typically see the salt and pepper nuclei of typical neuroendocrine tumors, and moderate amounts of cytoplasm that can be more basophilic or more eosinophilic based on, sometimes based on the type of hormone that they make and the actual background. So in the past, we only did the hormones, and then if all the hormones were negative, we would call those null cell adenomas. However, now we know that most of those that we used to call null cell adenomas are actually gonadotroph adenomas that will make, so they will express SF1, but just don't make enough hormone, or they don't make conformationally stable hormones to be picked up by immunohistochemistry. So with the current classification, you actually have to have negative transcription factors in order to call a tumor null cell adenoma. What else? So there are some features that can help histologically in terms of deciding which one. This is an interesting thing. I think it's a PES thing, to determine what type of adenoma we're looking at. But in reality, immunohistochemistry is what's going to help you the most. And so there are 5 subtypes of adenomas that are considered special types because they have a higher risk of recurrence than other adenomas. And those include silent corticotroph adenomas. So adenomas that make ACTH, but do not cause Cushing's syndrome. Silent corticotroph adenomas. Then we have of the somatotroph adenomas, so tumor that makes growth hormone. There's 2 types. They're called sparsely granulated or densely granulated. The sparsely granulated one is the one that's called special and has a worse prognosis. And we can identify it by using keratin stain, CAM 5.2, that will demonstrate a pattern of fibrous bodies. So basically like a round structure in the cytoplasm adjacent to the nucleus in majority of tumor cells. The densely granulated ones just have diffuse cytoplasmic staining with CAM 5.2. Lactotroph adenomas, so adenomas that make prolactin in men, is also one of the special ones. And then plurihormonal adenomas, so there are plurihormonal adenomas that PIT1 positive plurihormonal one, also has a higher risk of recurrence. And then lastly, there's another type of corticotroph adenoma, also on that list, that is called Crook cell adenoma. So it has a characteristic appearance of the cytoplasm with a ring-like glassy eosinophilic background. It's actually intermediate filament formation around the nucleus. And so that is usually a response of the normal corticotrope cells. So the cells in the pituitary that make ACTH respond to the presence of ACTH with that change of the cytoplasm. It's called Crooks-Highland change. But when you have that in a pituitary adenoma itself, in the tumor cells, then you can call that Crooks cell adenoma. And again, it's one of the 5 in the list of special adenomas. Important with pituitary adenomas is that you can only call something pituitary carcinoma when there's demonstrated presence of metastases, whether it's systemic metastases like bone, liver, lung, or CSF spread. And the point about that is no matter how ugly a pituitary adenoma looks, whether it's pleomorphic or lots of mitotic activity, that does not make it a carcinoma. So whenever those things are present, we can describe them. We can say pituitary adenoma with significant pleomorphism or with increased mitotic activity. But again, that cannot be designated as carcinoma. I think that's pretty much the gist of and the other thing about pituitary adenoma, similarly to what I was talking about with meningiomas of WHO grade 1, in which Ki-67 is informative as to the risk of recurrence for these tumors, is the same for pituitary adenomas, and the recommendation is that you do Ki-67 and report proliferation index in all pituitary adenomas as well.
So I have a question. In case of those plurihormonal adenomas, which will stain for basically everything, and so we had a case similar to this, where all the stains were staining, just the prolactin was very strong. Is like we were having a hard time differentiating whether it is hyperplasia versus adenoma. How do you deal with such cases?
So that is a very good question. So hyperplasia should be differentiated by the actual architecture in the background. So if you have sheets of cells and you do, for example, the most useful stain in that context is a reticulin stain, which will highlight the normal lobules in the normal pituitary. In a hyperplasia, you're not supposed to have breakdown of the lobules. You will have expansion of the lobules, but there's still preserved architecture to a certain extent. Whereas in adenomas, that is blown through, and you have a monomorphous population without any reticulin, with basically no reticulin network between lobules, because the lobules are no longer there. I mean, I think that's the best that I can come up with. I very rarely diagnosed hyperplasia. And again, I think the presence of multiple, if morphologically they're uniform and there is no lobulation, that should be an adenoma.
Right. And we had another case where they were going after what they thought about meningioma, and basically it was they were intracellular, and we got pituitary tissue, and the question that we did the reticulin and everything too. The question there was whether it is a normal pituitary versus a pituitary hyperplasia. Is there any way to know that?
So again, the size and the shape of the lobules is what's going to help you there. And the presence of the multiple cell types within each lobule is what characterizes the normal pituitary. But again, with a surgical specimen, sometimes that can be quite challenging to determine.
Okay, thank you very much.
All right, you're welcome. It's 5:03. I think we're going to stop for today.
This was an excellent session. I enjoyed so much, and I'm sure everyone enjoyed as well.
Thank you so much.
Thank you.
Thank you, everyone. And I'll see you again on Friday then.
All right. Thank you very much, Dr. Martinez. Thank you.
Bye.